Hello, my name is David Grenache. I'm a professor of pathology at the University of Utah and a medical director at ARUP Laboratories. And I want to speak to you today about cell-free DNA tests for non-invasive prenatal aneuploidy screening. So let's start with a discussion of what aneuploidy is. Normal human cells contain 23 pairs or 46 chromosomes. An aneuploidy is an abnormal number of chromosomes and occurs during cell division when the chromosomes don't separate properly between the two cells. I'm talking today about aneuploidies as a genetic disorder in which an egg or a sperm contain an extra copy of a chromosome that is then inherited by an embryo. The most common aneuploidies among live-born infants are those in which 3 copies of either chromosome 21, 18, or 13 are inherited. These are referred to as trisomies because of the extra chromosome. The phenotypes of trisomic individuals varies substantially depending upon the chromosome that's actually inherited, but intellectual disability, sometimes severe, is common to all. Because it's the most common trisomy among live-born infants, I want to start with a historical review of prenatal screening for trisomy 21, also known as Down syndrome. In the 1960s, there were no tests for Down syndrome screening, and risk was based solely on maternal age and had a detection rate of 27%, very low, and a very high false positive rate. The introduction of the double screen in 1984 ushered in a new era of screening using AFP and HCG measured in maternal blood. And over a decade, other biochemical markers were added to the double screen, and at each step, the detection rate increased and the false positive rate decreased. First trimester screening became possible in 1997, and soon after that, a screening protocol that integrated both first and second trimester biochemical tests achieved the highest detection rate and the lowest false positive rate of all of the biochemical screening tests. Most recently, cell-free DNA-based screening tests have become available that offer very high detection rates and very low false positive rates and will be the focus of my presentation. Prenatal screening means many things, but it is often understood to mean screening for fetal defects such as the trisomies. Biochemical screening tests continue to be the most widely used, and these tests are designed to detect either T21 or T18. Cell-free DNA testing is becoming increasingly popular, and in addition to screening for trisomies 21 and 18, the latter, they can also detect trisomy 13, Fetal syndrome, which is not specifically screened for by biochemical screening. The discovery of cell-free nucleic acids in the maternal plasma in 1997 opened up new possibilities for aneuploidy and other types of genomic screening protocols. Largely derived from the placenta, fetal DNA represents about 10% of the total circulating DNA in maternal serum, and methods to detect and interrogate fetal DNA have been developed that identify the molecular pathology of aneuploidies rather than rely on the determination of a biochemical phenotype. These tests are often referred to as non-invasive prenatal testing, or NIPT, but actually that phrase lacks specificity, and technically there are several tests that could be categorized as NIPTs, and so really a preferred term for this type of testing is cell-free DNA testing. There are currently 5 companies in the United States that offer DNA-based screening tests using related but slightly different approaches. 3 companies use massively parallel shotgun sequencing to detect an increased copy number of specific chromosomes, while the other 2 use methods that amplify specific targets on specific chromosomes. And while the methods may differ, they all have the same goal. That is the detection of extra copies of a specific chromosome. In massively parallel shotgun sequencing, fragmented cell-free DNA is isolated from maternal serum, it's amplified, and then the first 36 base pairs of each fragment is sequenced. The sequences are mapped to a specific chromosome, and the number of unique sequences are counted and are compared to counts from a reference genome. An excess number of sequences for a specific chromosome identifies an aneuploidy. Importantly, this method makes no distinction between maternal and fetal nucleic acid sequences. Another approach is to use single nucleotide polymorphism sequencing, or SNP sequencing. SNPs are the segments in the DNA sequence that can vary from person to person. One lab uses this method to identify over 13,000 SNPs to determine the number and identity of each allele in DNA obtained from maternal plasma and maternal white cells. An algorithm then uses those sequence data to construct billions of theoretical fetal genotypes and then is able to estimate the risk of fetal trisomy from those estimates. Targeted DNA sequencing is similar to massively parallel shotgun sequencing, but it's limited to mapping sequences of specific chromosomes only. That reduces the number of sequences, and thereby the costs, needed to produce a result. And as a screening method, this method's detection rate is best for trisomy 21. This table summarizes the literature regarding the performance of the various commercially available cell-free DNA-based screening tests. All tests have high detection rates and low false positive rates for trisomy 21 and 18, regardless of which molecular technique is used. Detection rates for trisomy 13 are somewhat lower, but the false positive rate remains less than 1%. I haven't included data from the Quest test because it's a new introduction as a commercially available test, and there are very limited data available. The combination of high sensitivity and low false positive rate has the potential to be misleading if the positive predictive value, or the PPV, of the test is not considered. As the proportion of true positive results divided by the number of all positive results, whether they be true or false, the positive predictive value answers the question, what is the probability of an affected fetus given a positive result? Importantly, the positive predictive value of any test is dependent upon the prevalence of the condition in the tested population. For the trisomies, prevalence increases along with maternal age, and you can see that the PPV increases along with the prevalence. In other words, the more prevalent a disorder is, the more likely it is that a positive result will be a true positive, and vice versa. The lower the prevalence of the disorder, the more likely it is that a positive result will be a false positive result. And while a positive predictive value of, say, 55% shown here may seem low, barely better than a coin toss, it's considerably better than the positive predictive value of the best biochemical screening test, which, because of its high false positive rate of 5%, produces a positive predictive value of only 6%. Currently, most professional practice guidelines recommend that cell-free DNA screening tests only be used in high-risk pregnancies. And a high-risk pregnancy is one that's defined by one of these conditions shown in the table: a maternal age of 35 years or older at delivery, ultrasound findings that suggest increased fetal risk for aneuploidy, history of a previously affected pregnancy, or a positive biochemical test for an aneuploidy, or a certain type of chromosome rearrangement that increases the risk of either T13 or T21. The main reason for this recommendation was that all initial studies of cell-free DNA performance were conducted with women at high risk of having an affected fetus. However, data are now emerging from the use of these tests in the general obstetrical population, and all indications are that they perform equally well. In fact, just this year, the International Society for Prenatal Diagnosis was the first group to state that cell-free DNA tests were appropriate as the primary screening test for all pregnant women, regardless of risk. ACOG also updated their guidelines, and whereas they previously discouraged cell-free DNA testing for the general obstetrical population, they now state that these individuals should be able to choose that type of testing, but ACOG still encourages the use of conventional screening tests, that is biochemical tests, as the first-line screen. ACOG's reluctance to recommend cell-free DNA testing for all women includes the lower positive predictive value in low-risk women and the limited data on cost effectiveness. And that's an important concern, because the cost of cell-free DNA tests are quite high compared to conventional screening tests, and widespread screening will be expensive at their current prices. But they are also more accurate than conventional tests, so the increased cost of cell-free DNA screening have to be outweighed by the lifetime cost of live Down syndrome births. A study by colleagues at the University of Utah demonstrated that the cost-effectiveness of cell-free DNA screening depends on perspective. From a societal perspective, cell-free DNA screening becomes cost-effective when they are cost at less than $550 per test. However, it's not as cost-effective when analyzed from a more limited perspective, such as that as the payer, who may not consider the lifetime costs of live Down syndrome births. In that case, cell-free DNA screening becomes cost-effective at less than $217 a test. Regardless of whether biochemical or cell-free DNA screening tests are used, the results are interpreted similarly. A normal result means low risk and no more testing is required, whereas an abnormal result should be followed up with diagnostic testing. Until costs of cell-free DNA tests decrease, one approach is to use a contingent screening protocol in which biochemical screening is offered to all women, and only those that have an abnormal result would have cell-free DNA testing. So in other words, the cell-free DNA test becomes a secondary screen. However, a major disadvantage to this approach is that the detection rate of biochemical screening is less than that of cell-free DNA screening, which would mean that approximately 15% of affected pregnancies would go undetected. But that could be remedied by decreasing the risk cutoff that's used in biochemical screening to identify an abnormal result. That would certainly increase the detection rate, but it would also increase the false positive rate. But fortunately, because cell-free DNA screening would be used as a secondary test, those false positive results would then be correctly identified as true negatives by the cell-free DNA test. So here's an example of what I'm talking about. Imagine we're screening 100,000 pregnant women in the general obstetrical population, and we'll assume a prevalence of Down syndrome of 1 in 300, which would mean that of those 100,000 women screened, there would be 333 Down syndrome pregnancies. If we screened everyone first with the first trimester combined test, but we decrease the cutoff that we use to identify an abnormal screen, if we decrease that to 1 out of nearly 1,500, we get a very high detection rate, nearly 95%. In other words, we would detect 315 of those 333 affected fetuses. But we'd have an unacceptably high false positive rate of 21%, and we would have over 21,000 false positive results. If this were the only screening test we use, we wouldn't take this approach, but we have a secondary screen to consider. We'll do cell-free DNA screening on all initial screen positives, and because of the higher performance of cell-free DNA, we get really great results. So it has a 99% detection rate, meaning we would now detect 312 of those 315 initially detected affected fetuses, but look what happens to the false positive rate. It drops to 0.08%. We only have 17 false positive results out of the initial 21,000. Overall, this type of contingent screening protocol would give us a detection rate of 94% and an overall false positive rate of 0.02%. And that, in turn, leads us to a positive predictive value of 95%. And because this is a screening protocol, anyone that got through this protocol with a positive result on the other end would be referred to diagnostic testing to confirm the screen result. It should be noted that cell-free DNA tests fail to produce a result in 1 to 8% of samples, usually because there's a low fraction of fetal DNA in the sample. And that can occur in heavier women because they have a higher blood volume, but it also can occur in aneuploidic pregnancies. Some studies have failed to account for these no-calls when reporting detection rates, which has the effect of overstating test performance. And because repeat testing in these individuals is not often successful, and because a low fetal DNA fraction increases the risk of having an affected fetus, ACOG recommends that such women receive genetic counseling and be offered diagnostic testing rather than additional screening tests. It's clear that cell-free DNA tests outperform conventional biochemical screening tests for detecting fetal aneuploidies. However, this better performance has led some to perceive that cell-free DNA test results are conclusive. That is, they are essentially diagnostic tests. But that could not be further from the truth. False results can and do occur. Unfortunately, there are reports of women making decisions to terminate pregnancy based upon results of cell-free DNA tests. And it must always be stressed that these tests, despite their fantastic performance, are screening tests, and abnormal results should always be followed by invasive diagnostic testing to determine fetal karyotype. So in summary, cell-free DNA tests identify the molecular pathology of aneuploidies rather than relying on the identification of a biochemical phenotype like we do with conventional biochemical tests. Cell-free DNA screening tests have very high detection rates for aneuploidy, that is, they're very sensitive, and they're also very specific, meaning they have very low false positive rates. It's important to remember that an abnormal positive cell-free DNA screening test has to be interpreted with an understanding of the positive predictive value, which means understanding the prevalence of the disorder in the individual screened. And as I've shown you, a contingent aneuploidy screening protocol is a logical one to follow, until which point cell-free DNA screening tests become cost-effective to become the primary screen. Thank you for your attention.